Everybody, Dr. Rob Silverman here. Proven Health Alternatives. I have the SIBO queen, Allison Siebecker. We were practicing that before. She
You
is
got it.
without she's without question going to lay down some great groundwork on small intestinal bacterial overgrowth. But before we get into it, I just want to say hi. Thanks for coming. I'm
Thanks for
excited to
having
learn
me.
from you.
Thanks for having me, Rob.
It's my pleasure. I mean, this is a topic. I mean, this is truly a topic of conversation. I know a lot of the general public may not know about it. They're learning about leaky gut. So, SIBO, let's give some background before we delve in. Excessive bacterial overgrowth in the small intestine. The small intestine typically has a relatively low level of bacteria. It is the largest section of the digestive tract. It's where nutrients are absorbed in the bloodstream. It's also where there's a malabsorption of nutrients, which are B12, iron, thiamine, niacin, and some other fat soluble vitamins. Let me give you some SIBO factoids. SIBO is present in about 9% of the people with celiac disease in the US. There's a direct correlation between people who take proton pump inhibitors and SIBO. And I can tell you this, I'm going to give you one caveat. SIBO can cause leaky gut can cause SIBO. Take the football, run with it, enjoy.
Okay, well, fantastic, laying of the groundwork there because, SIBO sounds like its name, as you described, an overgrowth of bacteria in the small intestine. I think the first thing that confuses people, though, is what is this bacteria? And it's odd. It's not, people always think if bacteria is causing a problem, we call it bad bacteria. Um, but then when we get medical about it, what does that actually mean? It's not pathogenic bacteria that are overgrown. It's not a typical standard infection. It is bacteria that would normally be existing there in our digestive tract that now has overpopulated, overgrown, overcolonized. The balance has gotten off. And when that happens, they can cause all sorts of problems, interfering with digestion and absorption, which you explained occurs in the small intestine. But now we have actually an expansion of the definition as more and more research has been done. So we have three types of SIBO that are based on the gases these overgrown microbes make. And these are the hydrogen, methane, and hydrogen sulfide. Well, where this definition has expanded is now we know that the bacteria and actually archaea, so some of these microbes are not bacteria but archaea or methanogens, that are overgrown that cause the methane and the hydrogen sulfide can be overgrown in the large intestine too as this same clinical entity. So because of this, the names have changed. Used to just all be called SIBO, small intestinal bacterial overgrowth. But now we know that two of these forms can overgrow in the large intestine, and one isn't even a bacteria. So the B in SIBO for bacteria just wasn't like technically correct. So now we have intestinal methanogen overgrowth or EMO. That was what we used to call methane, SIBO. And we have ESO, intestinal sulfide overproduction, which
Great
is
stuff.
when these hydrogen sulfide ones overgrow. So the definition's expanded, but honestly, I just still call it all SIBO because that's what it was called forever and it's easier.
Outstanding. So there's three types of SIBO. And I guess we should say that the small intestine is about 90 to 95% of the length of the intestinal tract. The other
Yeah.
5 to 8% is the large intestine. The large intestine is where most of the bacteria should be housed. Now, I'd love you to make that differentiation in a small intestine. It's not just an overgrowth of bad bacteria, it's an overgrowth of bacteria.
Yeah. So, and the methanogens can overgrow there too, because, the three types can overgrow small or large. It's just the hydrogen type that seems to only be confined to the small intestine when it's overgrown. But they've actually, meaning Dr. Pimentel and team, these are our lead researchers in this field. They've been so diligent and they've actually figured out with incredible surveying of the small intestine and large, but particularly small, which bacteria are overgrown in each type. So for the hydrogen, it's E. coli and Klebsiella types. They do know the specific strains. And this is not the pathogenic type of E. coli. There's a pathogenic E. coli that can cause food poisoning. This is just the standard strains that exist in us normally. For the methane type, it's M. smithii, Methanobrevibacter smithii. It's a mouthful. And for the
Mm.
hydrogen sulfide type, it's Fusobacterium varium, Desulfovibrio piger, and then also Proteus mirabilis. So we actually know the exact bacteria and archaea that are overgrown causing this problem. And that's a great advancement. We didn't used to.
Wow.
We used to just think it was like the general population was too many. But now we know that's not true. There's a ratio issue, and certain ones are overgrown. It's like Dr. Pimentel describes it as a few weeds overgrowing in the garden, and then it causes havoc in the garden. So the fact that we now know what they are is really helpful because our treatments can be more verified and more specific, aimed at those exact culprits that are overgrown.
Well, let's delve right in. You've been so kind. We were talking before. You've got that big effervescent smile. Here we go. The testing and not guessing of SIBO. There's a lot of controversy. What's the best test? What does it mean? How does it differentiate between small intestinal aspirate procedures, etc.?
Okay, so generally there's three ways we could figure out if somebody has SIBO. There would be, as you mentioned, like a endoscopy with culture or DNA testing, like an aspirate, right? This has a lot of problems. This would be considered the gold standard in everybody's mind, right? But it has a lot of problems because culturing that area is very difficult. Sometimes you can't, like the exact place you touch might not be the place with the overgrowth. It's, as you mentioned, it's like 18 to 25 feet long. Instruments can't reach usually past the ligament of Treitz, so it can be very difficult. Then many of these are anaerobes. They don't culture well. There's all these issues. There's contamination with oral bacteria, on and on. So the gold standard that we imagine in our mind, why can't you just figure out what's in there? We call it like a tin standard. It's not a very good standard.
Right.
However, and I'll describe the other two in a minute, but I will just say that Dr. Pimentel has done amazing work where they have actually advanced the technology, protecting from contamination, being able to reach farther. He developed and validated a new sampling technique. So this test is getting better. So there's that, right? Another way we could do it would be by blood. There's actually a blood test that can test for one type of SIBO. What I mean by one type is SIBO that is caused by one particular cause, which is food poisoning, which happens to be the most common cause of SIBO.
Right. Yes.
So there's a blood test that can check for autoantibodies against the bacteria that would cause this and the toxin that they release that is the trigger for this type of SIBO. So there's a blood test. But the problem with that, it's great, but the problem is that if you have SIBO from another cause, it would be negative. So, it's a
Mm.
wonderful screening test, being that it's the most common. And I do really like to use this test a lot. But the test that we all use clinically is a breath test. And this is the one that has all the controversy that you're
Mm.
alluding to. So
Sorry.
we use a sugar substrate to basically feed the bacteria. What happens is they feed off carbohydrates, the methanogens in the bacteria. And when they do, they ferment it into gas, those gases that are the types of SIBO. And so that's what we're trying to do with this test. It's a challenge test. We're trying to provoke the making of the gas because the hydrogen and methane gas, humans don't make that gas. So by proxy, we'll know if there's an overgrowth by how much there is and the timing of it. So this is what we do. That gas goes through the digestive tract to the lungs, is expired. So that's the nature of the test. Now, where the controversy comes in, there's multiple controversies. One is which sugar substrate is the best.
Mm.
Big arguments about that. How long should you do the test for? And in general, how does it compare to that aspirate culture testing, right? This is where the main controversy has come from, is the fact that when we compare breath testing to culture testing, it hasn't lined up too well in the studies. We
Mm.
now know the reason why is because the culture testing is so flawed. And so now that Dr. Pimentel has figured out a new sampling methodology and technology, and validated that, lo and behold, the breath tests are lining up with the culture tests. But
That's
this
good.
is absolute cutting edge research that most people wouldn't know about. You have to be attending the conferences and reading the abstracts, and not all of it's published yet.
Right.
So that one, in my mind, that's fairly well solved. But I know not everyone thinks that. Next would be which sugar. So this is another, I would say the second biggest place of controversy with the testing is Europeans really tend to like glucose. Americans tend to more like lactulose. But when you look at the studies, glucose always tests better. So why is it that we all like to use lactulose? And why would glucose test better? It's because um, all organisms will ferment glucose pretty much, but maybe not all organisms will ferment lactulose. And the other thing is that the glucose tends to have a very actually high false negative rate. And that's a problem. And the reason
Wow.
is that glucose is absorbed very quickly, within about two to 3 feet of the small intestine, which means the next 18 feet isn't being tested. And that's where SIBO is more common, is in the middle to lower portion. So with lactulose, we get, what the concern is, we might get more false positives, but there's a way to interpret tests to figure this out. There's things to look for. And of course, remember, interpretation of any test is an art. It's not black and white. We use history, we use our medical intuition, we use many factors, not just a number on a page. So what I can tell you is that clinically, we find this lactulose breath test to really line up with the patient experience with our treatment. We retest after, we see the changes, and we correlate it to the symptoms getting better. So if somebody was just reading studies and didn't have much experience, they may think it's all bunk, or they may think they should just do a glucose test. And usually they're going to be disappointed. But when you get in there with a clinic and you start really working it and correlating it to the reality, you see that it's quite reliable. And I couldn't imagine treating SIBO without it. And I know I'm talking a lot, but let me say one more thing here. The other thing about the test that's so helpful with the breath test is we see which gases are there and in what amount. It's a parts per million. And why this is important is because our treatments are chosen, at least two of our main treatments are chosen by gas type, because we have to target the different organisms. And obviously, we know different treatments work on different organisms. So you actually need the information of which gas is present and also the amount, because we choose different treatments based on the amount. So it isn't a yes or no sort of test. It's very helpful to pick and choose our treatment. So there. Now I've said my fill.
There's a lot to unbox, but I like what you said, especially where you're taking the test findings and correlating it with the patient's symptoms,
Exactly.
because that's like a double check. So I'm going to do something very New York. You told me you grew up close to New York, so we'll see
I
if you can
did.
hang with me. We're going to do a little rapid fire, and we'll do true false. We'll make it
Got it.
even quicker.
All right.
Hydrogen methane breath test. It is a common method of assessing SIBO.
True.
Hydrogen has a better association with diarrhea.
True.
Methane is almost exclusively associated with constipation.
True and false. We have exceptions to the pattern, but that's the
Okay.
pattern.
Okay. I mean, throw it out there. Go ahead.
Yeah.
Did you want to
Well,
dive?
yeah, that is the pattern is that methane we know can actually cause constipation. It's called a gasotransmitter. It's a gas that interacts with the nerves in the small intestine and also large intestine, and it can slow transit time and motility. But we often see people where that pattern doesn't hold. Even in the studies, it's like 95%. So, 5 to 10% may not fit. But we do see exceptions to the pattern, but it is the pattern.
And one other test is a 3 hour lactulose test versus a glucose test. The lactulose test is preferable.
For me, it is yes. I would advise yes.
And all our colleagues are going to ask, so I'm going to put you on a hot seat. I apologize for this. I do like you. Do you have any no? Do you have any numbers, sensitivity, specificity, accuracy of these tests? We know they are the gold standard.
Yeah, not in front of me, but actually, some of the numbers are very good. When you look at the randomized control studies on lactulose breath testing, it's good, particularly when you check it against for IBS, when you're looking to try and figure out is somebody's IBS SIBO. They actually come out quite good.
You know, you
Yeah, and we
mentioned
should
that. I'm sorry. You
And we should
mentioned
be,
IBS a couple of times.
oh yeah, yeah, yeah. I just want to
So
say we should be having a grand master testing article coming out that will like look at all the stats. And so in 2025, look for that.
great, great. I appreciate that. You mentioned IBS, irritable bowel syndrome, which is 1 in 9 people get it from food poisoning. IBS has a correlation to SIBO. So once again, I'm going to pass the baton to you on that.
Well, I can give you the stats on that one because I have that memorized. And
Sure.
that's about anywhere from 60 to 84% would be like the average of, so I like to say 70%, just putting it in the middle there. Of IBS patients, it's due to SIBO. They actually have SIBO. That is what the IBS is. For all the other people that aren't in that statistic, what is their IBS from? I mean, we have a 40-item differential diagnosis list for that, parasites, yeast overgrowth, and on it goes. But a large portion, the majority of IBS patients, it's caused by SIBO. That is the reason that we care. It's causing a huge suffering to so many people. We have an answer now for why people with IBS have it, and it's this bacterial overgrowth or archaeal overgrowth. We know how to treat it, and the treatments are very successful. So we can get in there and help people now. Whereas previously for IBS, all we had to offer really was symptomatic relief. Here's something for your constipation, here's something for your diarrhea. We really don't have anything for your bloating, and it's like now we have an option.
So I'm going to give you a list of symptoms, SIBO symptoms. And then I'm going to follow up with an interesting question, hopefully interesting. Nausea, bloating, vomiting, diarrhea, malnutrition, weight loss, joint pain, chiropractor, fatigue, number one complaint in a doctor's office, rashes, acne, eczema, asthma, depression. These are all correct symptoms. If so,
Good.
they almost sound like the same symptoms as leaky gut. Help
There,
me out here.
there's one exception here would be vomiting. That is not a SIBO symptom, and nausea is less common, but can occur. But vomiting, no, that's usually something else. So, but yes, other than that, of course, stats are about 50% of SIBO patients have leaky gut. Why isn't it 90%? Isn't that astonishing that it's actually only 50%?
Crazy.
But it's true. I used to run a lot of leaky gut tests in SIBO patients, and not all had it. But it's a very common cause because SIBO is so common. It's a very common cause of leaky gut. So of course the symptoms are going to correlate, particularly when you get into the systemic symptoms, the rashes, respiratory, all that. That's all leaky gut. That's causing that.
So my takeaway is that SIBO can cause leaky gut. Leaky gut does not necessarily cause SIBO.
Yes, that would be how I would understand it. Yeah. And we could go over causes if you want, like physiologically in the body.
I think we're going to get to that. I got one more for you.
Yeah.
So really cool. I just gave an Alzheimer's talk and somebody asked me, does SIBO increase the incidence of Alzheimer's? And I said, I will check with you, but my understanding was no. Correct me if I'm wrong. However, it dramatically, precipitously, if you will, increases the incidence of SIBO with Parkinson's disease.
That's just what I was going to say.
And it's about a 46% increase. So, I mean, I think I know the answer, but why Parkinson's and not Alzheimer's?
I haven't looked closely to see if there's any new articles on linking Alzheimer's and SIBO. But what I do know about Parkinson's is that where all the research has been going is that they're thinking it's gut caused, right? It's originating in the gut. And SIBO is very common, and SIBO can lead to Parkinson's. We do know that. And also, just clinically, a thing to point out is that Parkinson's doesn't just happen to people who are elderly, right? This is a thing
Right.
we all have to remember. What is one of the first symptoms of Parkinson's? Constipation, right? So in a middle-aged or younger person, don't just ignore constipation. Do a little digging and check and make sure that these are not early signs of Parkinson's.
It's interesting. I didn't find anything with Alzheimer's, and I found that amazing because LPS, Candida, the ecosystem. Again, Alzheimer's now is an autoimmune condition, and we all know most autoimmune conditions come from the gut, i.e., that's why SIBO is so important and its correlation with Parkinson's. So I'm going to take a stab at it. I'm going to be Rob the prognosticator, and I'm going to say in the next few years, we'll find an effect that SIBO has on creation of Alzheimer's. It's just going to be a projection.
Well, we have at least 3 articles. So here's what I did. I went and I have a website that's free educational informational website, siboinfo.com. So I have a page on there, associated conditions, associated diseases. So I just went and looked, and we have 3 articles linking SIBO and Alzheimer's. But what we don't know, I think for sure yet, is it a cause? A lot of these we figure probably are, but that hasn't, when articles first come out, they show an association, right? And then later they can sort of link it and see. But, so there is an association between SIBO and Alzheimer's.
Look at that. I didn't even go.
So your prediction is already true.
So I guess innately I got it right. I got lucky. I had a 50-50 chance. Now, that said, we had talked about this before. There are multiple reasons, or really, I think there are 4 underlying causes of SIBO. Would you care to share them with everybody?
I don't group it as 4. I think that's how Norella Jacobi likes my dear friend. She likes to organize things in a slightly different way than I do. So I'll just explain my understanding of the causes. So there's really 2 main physiologic underlying causes in the body. One would be a deficiency of the migrating motor complex, and that is a form of peristalsis or movement in the small intestine that is the sort of main thing that keeps us from getting SIBO, right? So it happens when we're fasting, between meals, and overnight when we're sleeping, which is why actually snacking between meals is not recommended with this condition. So that is very helpful if you don't take calories between meals. Okay, so that's the number one. And then there are all kinds of reasons that could become deficient. There are many diseases, there are drugs, there are injuries that could cause a deficiency of the migrating motor complex. Second would be structural. So anatomic alterations, anything that's going to somehow block the flow of the bacteria getting through and out of the small intestine. And really our main one here is partial obstruction. And there can be all sorts of causes of that. I think the most common really is adhesions. Adhesions are like scar bands that form as a protective measure, maybe from injury, from surgery, extremely common from surgery, but also injury or infection or inflammation that occurs. And adhesions can form in the abdomen that don't cause a partial obstruction of the small intestine, but in this case, they are. There are other structural abnormalities that can lead to SIBO as well. Other things that can cause partial obstruction would be like a volvulus, a kink or a twist in the intestine, in inflammatory bowel disease, when there's a narrowing stricture, etc. There's other things, superior mesenteric artery syndrome, a compression. There's other anatomic abnormalities. One thing I guess I want to mention here is most people think, well, I don't have that, right? How do you know? How do you know if you have SIBO and you're struggling from it?
Right.
You actually need to check. So one of the tests that we used to run a lot is actually a barium swallow, because this would let us see how the fluid would move through the small intestine. Is there any obstruction? And if there are adhesions, we will see right angles. So there's ways we can figure it out. People just like, well, I don't have that. Volvuluses occur spontaneously. I've had multiple patients, they were fine. They got a spontaneous volvulus. They got SIBO, etc. There's diseases that can cause anatomical issues, like Ehlers-Danlos syndrome is probably one of the most common. The stats on IBS and SIBO in Ehlers-Danlos are very, very high. So this is a connective tissue disorder that is not rare, even though many people haven't heard of it. And what happens is the connective tissue becomes lax, and there's like prolapses, there's sagging, and then also motility doesn't work very well with a lax tissue. So that's another cause of also deficient migrating motor complex. So these are like the main causes. Now, in the physiologically. In the when we talked about the deficient migrating motor complex or just having a normal anatomy, these are natural protective things, are factors our body has. So there are other natural protections that many people like to think about as a potential cause of SIBO, like low hydrochloric acid with, like, for instance, taking a PPI, which suppresses acid. Or what about the ileocecal valve that separates
Yes.
all that bacteria in the large intestine from coming up? These are factors, right? So if you have these deficient or altered, they would increase risk. However, what studies have shown is that it's really the deficiency of the migrating motor complex or partial obstruction that are the main causes. And you can even have a bunch of these other protective mechanisms low, and you still might not get SIBO. But when you start adding in that deficient migrating motor complex, so I think for many people where the PPI comes in, is they already had a partially deficient migrating motor complex. Maybe not enough to cause SIBO on its own, but then they add in the acid suppression. Now you got two things together, half and half, and then you get the SIBO. Because it's fascinating. There are studies showing where they actually are achlorhydric people in studies that don't get SIBO so long as that migrating motor complex is working. So you pretty much always need to have a little bit of that or a partial obstruction.
Outstanding. Migrating motor complex, as you said, peristaltic wave-like contractions from the stomach through the intestinal tract to move the food bolus when that gets caught up. And I think that's a real salient point in the idea that if it is not contracting and pushing it, that food stays in this small intestine area.
Well, actually, the migrating motor complex happens between meals. It's the cleanup crew. It's called the housekeeper wave. So regular old peristalsis is what moves the food bolus. But once that's been moved, and really, regular peristalsis is not like a big movement. It's more of a this movement. It's like a just ever so
Mhm.
slowly moving down and presenting the food for absorption. But once that has finished, like let's say an hour, hour and a half, in comes the migrating motor complex. And that timing's a little different for everybody. And it's the cleanup crew. It's like washing the dishes after you've eaten. You clean
Great
up. So
stuff.
now all the cellular debris, any leftover food particles, etc., dead cells, now are getting washed. And it's like a physical scrubbing, like it's moving, but it also has soap because bile gets released with it and enzymes right with the migrating motor complex. So there's like a sudsing and then a moving, a scrubbing, cleaning. We have to have that. Our body has it going on all day when in between meals when we're fasting and overnight. If we don't have that, that's not good. And then bacteria can build up.
Great differentiation. So that really leads to the next question. If the migrating motor complex needs you not to eat, so a fasting state is probably very opportunistic to avoid SIBO. What's your feeling on intermittent fasting in reference to avoiding SIBO as a treatment protocol?
We have no studies on it, and I haven't done much with it, but theoretically, I love it. I love
Okay.
the idea of it. I mean, it seems like a great match. I guess there's one thing I would say, which is that there are many conditions where you do something that establishes the right terrain,
Mhm.
but when the condition is already entrenched, that isn't enough. You usually need to go in with a treatment to get you back down to like physiologic baseline. Then, when you do your terrain supportive things, you're in great shape. So, like just intermittent fasting itself, will it be enough all on its own? It might. It might. So, let me just mention one of the treatments we have for SIBO, which is elemental diet. And this is really meant to sort of be mock fasting. So, here's where fasting could come in as a treatment. So, elemental diet is, a medical food beverage where nutrients are in their most broken down form, or most of them are. And the idea is that it absorbs, because it's already pre-digested, it absorbs very quickly into the person before the bacteria get a chance to eat it and ferment it. So, in essence, it's starving the bacterial overgrowth while feeding the person. Um, but the thing is, what we've found is you need at least 10 days of this, really even 14. So, really, what would probably be the most effective in fasting is an actual like water fast for 10 or 14 days, which is quite difficult, right? That is, I mean, people do it. You know, I think I've gone as far as 5 or 6 in my fasting days, but it's not the easiest thing to do. And some fasting experts don't even advise it in today's
Mm,
chemically overloaded world, right? But I bet you there are stories of people who've done intermittent fasting where it has worked, because you always hear of these things, you know?
interesting. So you mentioned the elemental diet as a diet possibly to be used with SIBO. My understanding, or the common answer fill in, is the FODMAP diet: fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Well, one, explain that in more detail for everybody. And two, let's be real, the compliance to that ain't that high.
Well, this is wonderful. This diet's wonderful because they it's like one of the most studied diets I've ever seen
Mhm.
ever. And what so therefore that's what's particularly wonderful about it, is that means physicians will prescribe it and it can help. It is definitely not the best match for SIBO. And that's because it wasn't really created for it. So this diet removes um, oligosaccharides, which these are this is what the acronym stands for. They're in a lot of fruits and vegetables. It's a short chain carbohydrate. It removes lactose only if you actually are lactose intolerant. And while most SIBO patients are, not all of them are, believe it or not. But the FODMAP diet doesn't want you to remove it unless you know you're lactose intolerant. Most people forget that part and they just remove it. That's the milk sugar. It removes the disaccharide fructose, because they're like lactose. Some people can't handle it, but they only want you to remove it if you can't. And then I'm probably forgetting something else. Oh, and then the sugar alcohols is the polyols, and then they bring into it that osmotically active. Basically, that's not in the acronym. So here's the deal: is that this was really created for IBD way back, and maybe a little bit thinking of SIBO. But the problem is it doesn't exclude long chain fiber. This is like what we think of as, like psyllium husk or something. So SIBO folks, that's the hardest food for them, is fiber. In fact, refined carbohydrates tend to go easier, like sugar or glucose, sometimes fructose. It depends on the patient whether they can handle fructose. But it's the complex carbohydrates that cause sometimes the worst problems: starch, resistant starch, not always starch, resistant starch, fiber. And the FODMAP diet doesn't remove that at all. So you can easily modify this diet. And that's what we do. We have about 5 diets that we use for SIBO all the time. And you could just start someone on any of these diets, but then you just customize and tailor it to the person's tolerances, because everyone with SIBO, this is a very frustrating fact of clinical practice with SIBO, everybody's food tolerances are different to the next person. And so this is what would happen to me, is that, the 9 a.m. patient would tell me one thing that they could handle and one thing they couldn't, and the next patient would tell me the exact opposite.
Mm.
So this is frustrating for people and patients and for doctors. So if you want the best success out of the diet, you just start with any of them and you customize it, which means that you will be eating some of the things that the diet says you're not supposed to have, and you will be excluding some they say are perfectly fine because you're customizing it to you.
I've tried the FODMAP diet, and those who have complied, great results. Those that haven't, obviously not as good. I've used the keto diet. I was curious your feeling on the keto diet instead of the FODMAP, or in place of it, just because it may be a little bit more compliant. Taking into consideration it does elevate your cholesterol, and I know bile is a problem, and I know that's a rabbit hole, but I know you know what I'm saying.
Uh, it's similar. We haven't really used this as our main diet for SIBO, but theoretically, it should be good. What you probably want to do is take a look at the FODMAP app, or just lists online. You can look at my free diet, on my website, that shows you fruits and vegetables and basically plant foods and carbohydrates, what tends to be tolerated and what doesn't, so that when you venture into that at all. But generally, I think keto should work. We just don't have a ton of experience with it.
Well, here's another one for you. I know the answer to this one. I lecture, and everybody says probiotics for SIBO. I read somewhere that probiotics were not good. Right or wrong? True or false?
It's so complicated. I can't rapid fire that one. Okay, so here's the deal. Clinically, there isn't a consensus, which so you'll have people saying no, and then you'll have doctors saying yes, and then you'll have some in the middle. Myself personally, what I find is it depends on the person, right? How well the individual, if they're going to do well with probiotics or not. And it also depends sort of when. Sometimes people tolerate them better when they're sort of through the worst, the SIBO, etc. The issue is that the issue is cross feeding. So most probiotics don't make gas in and of themselves, right? They're not the bacteria that are fermenting carbohydrates into gas. Most probiotics make acids, but then those acids can be used by the overgrown bacteria to make gas. That's cross feeding. So basically, if you take a probiotic, you could have more gas production, which would make your symptoms worse. It possibly. Now, let's contrast this with all the studies. We have like over 45 studies on probiotics for SIBO, and they're good. I mean, I think there were maybe two studies that were like, meh. The rest are excellent. In fact, we even have studies that show that you could just use a probiotic for treatment and get rid of the SIBO. Personally, I don't know any patient or clinician that's been able to replicate that. It is so frustrating. This would be the most incredible thing if we could replicate what these studies have shown, right? Who wouldn't want it to just be like, take a probiotic and then the SIBO's gone? That would be the best thing in the world. We don't have that experience in our clinical practice. So it's a matter of trial and error. And also, which were the ones that worked in the studies? All of them. So my friend, you may know Dr. Michael Ruscio.
Hmm.
He likes to categorize. I like how he likes to categorize probiotics into sort of three categories: your Lactobacillus bifidus, spore. So that's like you asked me earlier about Bacillus coagulans,
Right.
or Bacillus clausii. I think has also been studied quite well for SIBO. And then we have Saccharomyces boulardii, yeast. All of those have been studied for SIBO with success. So, it's like everything they've ever tried in a study seems to have worked well. But in patients, what we find is there's a pretty hefty group that can't tolerate them. It really aggravates them. Now, one thing to always think about here is could it be the prebiotic in the probiotic? Many
That was my
probiotics come
next
with
question.
prebiotics, right? FOS, GOS, these are oligosaccharides, chicory, inulin. These directly feed bacteria. They directly often feed the overgrowth in people, making their symptoms worse. So we have to be quite careful with prebiotics. Sometimes they're tolerated, sometimes fiber's tolerated, but which and how much is individual. So general advice would be try a probiotic without a prebiotic at first, try any of them, and if it's not a match, don't take it. You could try another one or just wait maybe until later. Personally, I like to bring probiotics in during the active SIBO because if they get triggered or flared or aggravated, it's we could just stop it and we're in the middle of treatment anyway. We don't have to worry about it. But and one other thing is that when I have waited traditional 4 Rs, right? You replenish with your probiotics after you're done with your main treatment. When I have done that, because I saw mostly challenging cases who were complicated and it took a long time to get their SIBO gone and them in great shape, what would happen is then I'm rocking the boat. And I have found with patients like that, it's best not to rock the boat when you spent like a year getting them perfect.
Yeah,
So I
goodness.
like to bring the probiotic in before and before everything's all excellent. Get it in there and don't wait till the end. That's just from the patient population that I was working with.
I agree with you. First off, probiotics, and let's separate the prebiotic. And again, speaking to the studies, I have a study right here that talks about 4 probiotics, Asperlardi, which was studied on its own to be as effective as some medications, B. lactis, Lactobacillus acidophilus, L. plantarum. This particular study, and again, you said it was a study, it was not with patients per se. It spoke to the idea of really these 4 probiotics having a great association of decreasing symptomologies in SIBO, much more than people without SIBO. The B coagulants we talked about, like you said before, improve the symptomology. So for me, and I gather from you, I'm extrapolating you, I'm pulling you to my side. You're
What's
a
your side?
we're pro probiotic with SIBO, but at the right timing and always using the individuality. Prebiotics, which we think are a great longevity tool, great for most people, probably aren't that great for people that have SIBO because the prebiotic may feed the bad bacteria.
Now, this is a place people are so split on because I have colleagues who once the SIBO is handled, and because once you get
Hey,
that
Doc, I'm
bacterial,
going to interrupt you. Isn't this great
okay,
that we don't have to agree? Isn't it? And I am happy that everybody's seeing us have a conversation to understand that doctors just don't do things rote. We decide, we
everybody
look
has
at it,
different
and we have
opinions.
different patient bases. So we're going to have
And
slightly different
and
opinions.
I'm sort of in the middle of like, well, let me just see what a person can handle. Like, because I have colleagues who they have a strong opinion this way, strong opinion this way, you know. So there's those that say, gosh, once the bacterial load is down, you can handle fiber, you can handle prebiotics, bring them in. And they do, and their patients do great long term. Then you've got people like Dr. Pimentel who are like, oh my God, no, do not do probiotics, do not do prebiotics. It'll just spur a relapse. And probably he's had that experience. But then you have the people over here who said, no, they haven't had that experience. They've had the opposite experience. This just speaks to the individuality of different patients, different populations that we see, and there isn't one right answer. Specifically with probiotics, I'm definitely pro probiotics. One other thing I just want to mention here is many SIBO patients have histamine intolerance. We
Hmm.
didn't mention that a main underlying cause, unfortunately, of SIBO is mold, toxic mold illness, which leads to a lot of histamine issues and MCAS. And then people have a very hard time tolerating probiotics. So that is just something I wanted to mention. That could be just sort of an additional, almost non-digestive, so to speak. It's not like you're just having a fermentation reaction. You might be having a histamine reaction, and the patient can't handle the probiotic. So there's other things that need to be treated to be able to get them to tolerate it.
And really, to piggyback on what you said, it shows that patients, when they have some complexity of a condition like SIBO, leaky gut, mold, microtoxins, they shouldn't necessarily go just online to read, well, take a probiotic, take a prebiotic. They should seek out a functional oriented functional medicine practitioner to individualize and personalize for their outcome because these decisions are not just left and right, yes or no. You just don't pull the lever and turn it on because probiotics are something that, look, I sell a lot of them in my office, but the bottom line is I don't give someone a probiotic that has leaky gut all by itself, even if you give a probiotic at the beginning.
Yeah.
So I think that that's a point to the listeners that they should really understand, like get examined, get tested, don't guess, find the blind spot. And you know what? I was asked yesterday, a patient had a condition, had psoriasis, and he said, how many times have you seen this and what's your outcome? I was excited. I said, I think I'm going to treat you for free. You got me spurred on because it's like, that's a question you should ask a doctor. Have you seen SIBO? What do you think? How's your outcomes? That's okay because the jokers will be sent away and the real people stay standing like yourself. So now that we established that you're real, your terrain is strong, give me a SIBO protocol.
Okay, so we have three things to choose from here. Let me just give you the quick overview. When we're treating SIBO, there's three levels to think about. Symptoms, you know, alternative functional medicine practitioners, naturopaths, sometimes scoff at the idea of treating symptoms, right? But it's super important. We need to bring some comfort to people so they can like live their lives and complete the rest of the treatment. So we can treat symptoms. Then we treat the overgrowth itself, and we do that with antibacterials. And then the underlying cause. Do we know it? How are we searching for it? If we could treat the underlying cause, if we could figure out what it is and it's treatable and we could treat it, well, then, we still have to get that overgrowth down, but then we won't have relapses. Okay, so having said that, the main thrust of treatment is the antibacterials. We use pharmaceutical antibiotics, we use herbal antibiotics, and we use elemental diet. Those are our three options. So the protocols for pharmaceutical and herbal antibiotics are dependent upon the gas type. And so there's different combinations. Basically, we usually use one pharmaceutical antibiotic, which is rifaximin, or brand name in the US, Xifaxan,
Mhm.
for hydrogen. For For the herbs, we use usually either berberine containing herbs, berberine, oregano, or neem. And we usually use two of those together. We don't tend to do a lot more than two herbs because we don't find we get the gas down any lower than when we go to more herbs. So more is not going to be more effective. Now, for methane, we use rifaximin again for the pharmaceuticals, but here we have to do double antibiotic therapy because we're also treating the methanogens. So we add neomycin or metronidazole with the rifaximin, double. With herbs, it's the same principle. We're using berberine, oregano, or neem to target the hydrogen, and then we're adding in something for the methanogens, which would be allicin, which is an extract from garlic, right? So we tend to use very potent ones of that. We don't tend to use garlic oil or aged garlic or whole garlic because garlic can really trigger symptoms in a patient. It has a lot of FOS. We use more of like the purified allicin. Or we use this combination product called atrantil that has herbs in it that have been shown to work a little differently where it shuts off the production of methane. It inhibits an enzyme in the methanogen, shuts off the production. So again, double therapy there, something for the hydrogen, something for the methane. For the hydrogen sulfide, the main things we found to work are bismuth, which so pharmaceutically, we don't really have an exact pharmaceutical. Bismuth is like a mineral or a metal, right? It's not really an herb or a pharmaceutical, but bismuth, so that's like Pepto-Bismol, right? Bismuth can bind hydrogen sulfide for excretion and also has killing activity, or high-dose oregano. These are the things that we have found can really be effective against those hydrogen sulfides. So we use that in combination. We'll do something for the hydrogen, something for the hydrogen sulfide. So that's the pharmaceutical and herbs. Now, elemental diet works on all gas types. But it's a harder course, because it's kind of like fasting in that you're only drinking this medical food beverage. You're not consuming solids at the same time. So you're just drinking your food for 2 weeks. So, you have to get your mind prepared for that.
Would you add any bile acids, bile salts to that combination?
Such a good question. It turns out rifaximin, which by the way is the most unique antibiotic, it's an antibiotic with eubiotic properties, is how it's called. Because before I answer your question, because it doesn't harm the microbiome, it's been studied and shown to actually help the microbiome. So it doesn't decimate,
Wow.
it actually boosts Lactobacillus, bifidus, Fecalobacterium, and others. It's been shown. So it's extraordinary. It's the only antibiotic I know like that. So that's very nice to know. Also, the reason we use it is because it is, and here's the answer to your question, it only works in the small intestine because it's bile soluble. So, bile comes out in the small intestine, gets reabsorbed at the end of the small intestine. So when the rifaximin enters the large intestine, it crystallizes out and isn't very effective. But this is why it's so helpful. It doesn't absorb into the body's circulation. It just works right there in the small intestine. So yes, you could add bile with rifaximin to make sure it's working well, because if somebody was low in bile, the rifaximin may crystallize out and may not work. So that's always a consideration. You can add bile when you're using rifaximin.
How about some digestive enzymes like beta-HCl, pepsin, amylase, lipase, protease, catalase?
Yes, these are great fundamentals, particularly if you suspect anybody's low in hydrochloric acid. If they're low in hydrochloric acid, they're low in enzymes because hydrochloric acid triggers the release of enzymes. Or if you just think they're low in enzymes, those are some of those foundational body protections against SIBO. Enzymes and hydrochloric acid can kill bacteria. They're part of the body's protection. Always a nice idea to add those in. Yeah.
Now, these relapse rates of SIBO, I think it's like 45%. I'm sure you have a couple of numbers.
Oh, it's way higher than that. Way higher. It's huge. You should expect the majority. 2/3 are going to relapse.
Okay,
it's terrible, terrible damper, right? There it is.
Oh, okay. So begs the question, your numbers are higher than mine. At
Why?
least what we got in the data. Now, it's not you versus Rob or anything like that. It's just that you are the SIBO expert without question. So you've got the data right there in front.
Well, we do have some data. There was a big multi-center study, Target 3 study, and this is what showed this relapse rate. And honestly, it probably underestimates it. It showed so this is where we get our figures. About a third of cases are not going to be chronic. You treat it, however long that takes. By the way, something we didn't mention is most cases will need more than one round. So pharmaceutical is 2 weeks, herbal is 4 weeks, elemental diet is 2 weeks. That's one round. Most cases need 2 to 4, even 5 rounds. Why? It's not a typical infection. It's an overgrowth. We treat until we get effects. Each round does what it can do. Why not just continue the round longer? Believe me, we tried it. Sometimes it works, but the majority of time, the treatment we're giving has its effect within about the round, about maybe a week longer than that round. The effect peters out, and someone will actually begin backsliding and relapsing while still on it. So the effect peters out. It's done what it can do. You finish that round, you reassess, figure out what is needed. Sometimes gases shift. You do another round. Just keep in mind that you need often several rounds to just keep getting that overgrowth down. So it's not a typical infection. Okay, now having said that, back to the relapse rates. That's very, very important point because that trips up a lot of practitioners and patients. Okay, so a third of cases are not going to relapse. You take however many rounds you do, you get it gone, it's gone. It's never going to bother them again. They don't have to think about it. 2/3, it's going to come back. Why is that? Because primarily there is still an underlying cause present that is continuing to cause the SIBO. We have many underlying causes that are chronic that current medicine, even the brightest of minds, does not know how to eliminate, cure, right? Can be well treated and well managed, and so can SIBO. SIBO can be well treated and managed. Some people only relapse once a year, every 2 years. Some people relapse every 2 months, right? It depends on what the underlying cause is. But one thing is that many people, patients in particular, when they hear the word chronic, there's a misnomer where they think I'll feel as bad as I do now forever. Like that's what chronic means. Like this state I'm in will exist forever. That is not the case with SIBO. Our success rates, which I didn't mention for all of our treatments, are between 90 to 100% statistically. And clinically, I would say the same. I would say we see excellent success at treating, getting that overgrowth down. If you do a few rounds and, there are complicated cases. So then the symptoms are, usually 80 to 90% better. I always shoot for 90% better. I mean, that's extraordinary. A condition where, 90% better and if it's a chronic condition. So imagine your symptoms being 90% better. You just have to do something, some maintenance, some preventative measures in between or, in your remission time. And then it is likely to come back at some point, at which point you treat it again. That's annoying, but it's better than, not having treated it. So what do we do in these remission periods? We do usually a diet, some kind of SIBO diet. And by the way, what are SIBO diets? They're just low carbohydrate diets, which is why keto and all of those can be considered. Some kind of a diet customized to yourself to just help manage symptoms and just generally keep the carbohydrates somewhat lower. And then a prokinetic. And prokinetics can be pharmaceutical or herbal or supplemental. So either way. And what are these? These stimulate the migrating motor complex. That is the whole point, is they help stimulate the migrating motor complex that is deficient so that the cleansing wave can maintain that lower bacterial level that we now have. So just briefly, what are these? Pharmaceutically, it's prucalopride, which in the US is called Motegrity. We have low dose erythromycin. Erythromycin is an antibiotic, but in low dose, it is a prokinetic and it's used for gastroparesis in low dose. And we also have LDN. LDN, low dose naltrexone, is not a prokinetic technically, but it's been studied and shown to have prokinetic effects, and it does help many. Studied for SIBO, actually, as a prokinetic. Naturally, we often use iberogast. It's like it was a 9-herb, like German formula that's like a digestive tonic, and it studies really well as a prokinetic. Studied head to head against metoclopramide and cisapride excellently. Now it's a 6-herb formula in the US. They've changed the formula, but still good studies on it. And then we have ginger root. Ginger, we know, helps nausea. And that's one of the main reasons why, is because it is a prokinetic, moves downward. We have all of these ginger-containing prokinetic formulas on the market now, like motility activator, Modal Pro, on and on and on. And then we have a new one on the market that's bitter orange based. Bitter orange also studies very well as a prokinetic, and that one is by Gaia Pro. So there, that's the chronic lecture.
You covered that well. So let me extrapolate a little because I know the questions on YouTube are going to be, wait a minute. So what you said was about 2/3 of the patients relapse, but they typically relapse, but they're not as sick as they were before. We
Correct.
have to value that. It's kind of like back pain. You come in with a 10, it doesn't go from 10 to 0 in one round of treatment, but if it goes from 10 to 6, it is deemed a success. And people have to realize that.
And then when you go the next treatment, you'll probably get down to 4, and
Right.
then the next, yeah, it keeps getting better.
That's great because I think that's a big takeaway. We don't want people to be discouraged. We want them to be encouraged. Also, if you're not healing as quickly as the practitioner indicates, or he or she says you would at the beginning, hope that they get to the credo of functional medicine, root cause resolution, because there's something else there. Whether it was a brain injury, because there's a high propensity of people who have a concussion to have SIBO, whether it's vagus nerve dysfunction, whether it's endometriosis, et cetera,
Huge,
et
huge.
cetera,
TBI and endometriosis, huge with SIBO. Yeah. We
without
haven't gone
question.
even gone over all the diseases that, SIBO
We
is
could,
common.
I mean, SIBO, for us to try to really speak about it in an hour, it just doesn't give it enough time, but we're trying to give a wide Reader's Digest version. So, two quick questions for you. Number one, or in, we don't have to go into real detail, organic acid test, which is a test for
Oh yeah.
dysbiosis and leveling of good and bad bacteria. Where do you feel it pertains in reference and correlation with SIBO?
So this test can't distinguish between small and large intestine, but now that's, maybe not as important as we used to think it was, because now we know that this overgrowth can be in the large intestine. Where I would say this test is good is for maybe very young children who can't perform the breath test. Usually under about 3, they can't do it. Um, Parents can train their children. They just need to be able to sustain and exhale. And so use a balloon or something, just have them practice. But the problem is you're not going to get any data with an organic acid test on the gases, which gases are there, and that's how you pick your treatment, and the amount of gases. That's how you can project how many rounds of treatment you think you might need, whether you should use elemental diet or not, because elemental diet can reduce more gas in 1-2 week course than antibiotics or herbal antibiotics, which can save you a lot of time in your overall treatment. So if somebody has like 150 parts per million, you want to know that. That's high. That's very high. Because if you just did elemental diet, you might get it in 1-2 week round. Whereas if you use pharmaceuticals or herbs, it might take you 4 rounds. It might not. It might be quicker. Well, just average these, this is really gold information here, but average reduction for pharmaceuticals and herbs per treatment round is about 30 on average. Sometimes we see more and then we're thrilled. But so you can calculate, you can project how many rounds you think are going to be needed when you have the gas number. So organic acid, I would say if somebody cannot perform the breath test, but I don't really see any reason not to do it. We even have some new tests that are helping with the budgetary concerns. So I don't know if you've heard of the Food Marble. It's a handheld breath test device. It's new, so there's controversy. Not all doctors like it. Some love it. Others don't because it's new, right? So people are still learning it, deciding what they think of it. But from a practical perspective, it's amazing because it is the same cost as one breath test, and you can do, you know, endless tests with it, and
Mm.
and it's still viable. The patient takes it home. The results come immediately to the doctor, so there's no waiting, no turnaround time. An app guides the patient, so it's very user friendly. So, if it's budgetary issues that somebody has. Now, one other concern is the lactulose. Lactulose, unfortunately, is prescription in the United States. So that can trip up a lot of practitioners who don't have prescribing rights. That is really frustrating. It shouldn't be a prescription. It's basically a mistake, but it would cost a boatload of money to get it off. So here's an option. A colleague, Dr. Horolak, you may or may not know, probiotic expert and researcher, um, we're friends, and anyway, he did a in-office study where he compared the lactulose, glucose, and fructose as a testing substrate for SIBO, and he actually found fructose was the best, better than lactulose.
Hmm.
So this is a newer clinical entity for us, I'd say within the last, say, 4 years. But for those who can't, their patients can't get a hold of lactulose, you can't prescribe it as a practitioner. A lot of times what you can do is just ask a patient's, some prescribing doctor they're hooked up with, a primary care or something, to prescribe it. And usually anybody usually will prescribe it. But if that's not going to work, you could use fructose. So you can use any SIBO test. You can get a no substrate SIBO test and then just have your patient go and buy some fructose, from online, or, my local health food store has it in the bins, and use that. And you just need a scale so you can measure it out. So I don't see any reason why we wouldn't use that. Organic acid would just be some basic backup that's not going to give you all the information that you need.
All
Organic
righty.
acid, by the way, is an amazing test, but it's
Mhm.
not,
Not
it's not,
SIBO, not
yeah,
specific for SIBO. It's a
yeah.
great test for dysbiosis, unleaveling of good bad bacteria. We've got so much left to talk about. I wanted to talk about CFO. Unfortunately, time doesn't permit us. That's an exciting conversation for me. So before I let you go, and one, I want to thank you for taking time to really educate us on small intestinal bacterial overgrowth. I always end with my buddy in Switzerland, and he says, Rob, I listen to all your podcasts. Just give me 3 things that I can implement on Monday. The stage is yours.
If you suspect SIBO, which would be based on symptoms, get the lactulose 3-hour breath test. If you can't do lactulose, do fructose. But basically, do the test and find out if you have it. Don't guess. Find out if you have it. Because also, we're using antibacterials, so we should know if it's appropriate to use them. These symptoms could be caused by other things that don't need antibacterials, right? That's number one. Get tested. Find out if you have it. Number two, treatment is very effective. Um, just know to, whatever antibacterial you're going to use, customize it to the gas, and don't give up after one round. Retest if you can, especially if you can afford it. Now we've given you a budget friendly option. This is what I always do is I retest after to find out what's going on. If you still have symptoms, you may not have SIBO, right? People have more than one thing wrong at the same time, right? So figure out, that's honestly one of the best pieces of advice I could give is be methodical. That will save you time and money, even though you think it's costing you time and money. It will save you time and money. Retest and be methodical and work it through till it's gone. So that'd be my number two. And I guess number three would probably be make sure to do a prokinetic when you're in between your treatment rounds while you're assessing, retesting, figuring out what to do next, and when your SIBO's gone. That is a huge missing part of SIBO treatment. Add in a prokinetic for the remission periods to hold the gains you've made. So that's it. Test, then retest and be methodical, and use a prokinetic.
Outstanding. He's got his 3 things.
There you go.
I appreciate you. This has been great. That smile is very contagious. I appreciate that. I look forward to seeing you again. It's been my pleasure. Dr.
It's
Allison
been my pleasure.
Siebecker.
Thank you for having me.
My pleasure.